It's my absolute pleasure to be here today talking about ambulance attendance data. We've been presenting on this for a number of years now, and today I'll be presenting on findings for 2014-15 data. And normally we're a little bit more timely than this, and there are a couple of reasons why we've got this little bit of a time lag that we don't normally have. It's still incredibly timely data when we think about indicators of alcohol and drug-related harm, but a couple of things have happened in the last 2 years. One of the first things that happened, and it's important to note, is there was some industrial action with Ambulance Victoria in the last 3 months of 2014, and specifically for our data purposes, the last 5 days of September 2014 and all of October, November and December, where paramedics were still treating patients, but they weren't recording any information about those treatment episodes. So we didn't have any data for just over 3 months. So to be able to understand what was happening across the last few years, we actually had to wait until data for the following year came in and was coded to be able to give us a better picture of trends over time. So that's caused us a little bit of a delay. The other thing that's happened, and we're very delighted to be launching today, Ambo-AODstats, which is an interactive website that makes this information accessible for anyone in the community to interrogate the data and have a better understanding of what's happening at the local area level, at the regional level and at the state level in terms of acute alcohol and drug-related harms. So first things first, I'd just like to acknowledge contributors to this project, and it's really a massive piece of work, and I'll talk a little bit more about the history and the context of the project. But this work is funded by the Victorian Department of Health and Human Services, and it's a collaboration with Ambulance Victoria, and we absolutely couldn't do the work without the ongoing support and engagement of Ambulance Victoria, both through data provision, which obviously we wouldn't have a project without having data to report on, but also really importantly providing feedback into any changes that are occurring into paramedic practice, into the IT systems that paramedics use, and also cultural shifts in the paramedic workforce that might change the way information might be reported. So it's an ongoing dialogue and it's an ongoing relationship, not simply a handover of data and then no discussion about the context or what might be going on to inform what's happening on the ground. Also, very importantly, this is very much a team effort, and we have quite a substantial coding team here at Turning Point who work with the ambulance data, and many of whom are in the audience today, and work on this project, but also on national work we're doing for the Commonwealth Department of Health and work we're doing with Beyond Blue and Movember around men's acute presentations to ambulance following self-harm, mental health or AOD related events. So we couldn't do the work without the dedication and consistent fantastic effort of our coders and of the research team, including Sharon Matthews, Jessica Killian, who's here today with her little bub, Gennady Bakshiv and also Mark Hoffman. So thank you all very much. And I'm really just representing this massive team effort. So to give you a little bit of a background, alcohol and drug-related harms are a really significant issue in our community, and we see that every day in the media, but we also see it every day in our community. We're affected by the impacts of others' use of alcohol and other drugs, and quite often by our own use of alcohol and drugs, either in an acute way or in a chronic fashion. The problem is, though, that when we're trying to better understand these harms and how they impact on the community, how they impact on health services and how they impact on our systems more broadly, we have quite limited information, and much of that information isn't timely. We know that things like population health surveys can be quite limited in terms of capacity to give timely reporting, but also in their capacity to capture populations who may be underrepresented. So it's really significant that we work with first responders to be able to address these issues and better understand what's happening at a community level. So ambulance data has been used historically to a limited extent, primarily focusing on illicit drugs and particularly things like heroin overdose. But we've used it much more broadly to look at alcohol and drug-related harms in the community, and also in other work we're doing now around self-harm and mental health, and also the impacts of violence. Ambulance data, unlike most other data systems, allows us the capacity for timely reporting and to address the delays that we see in other data systems. So when we're thinking about alcohol and drug-related harms, many of the indicators that we use have quite a significant time lag. If we're talking about treatment system data, there's often a 6 to 12 to 18 month time lag before that's finalised with data custodians. When we think about populations who may use specialist alcohol and drug treatment services, it's only one part of the picture of alcohol and drug harm, and certainly doesn't really capture that acute drug harm that we might be interested in. We know there are some real challenges in the reporting of alcohol and drugs in emergency department and hospitalisation data, that quite often, due to the environment in which that coding occurs and the nature of the process of treatment in those settings, clinicians will be recording information on the first issue that they're treating, or the most significant issue for treatment, and not necessarily the cause of that presentation. So if somebody presents and they're acutely alcohol intoxicated in an emergency department setting and they have a fracture as a result of a fall, it's the fracture that will be coded in the data, not the alcohol intoxication. So we certainly miss a significant proportion of drug and alcohol involvement in causes for ED presentations. We also know many people don't end up in the ED, and certainly fewer end up as a hospitalisation when we're looking at these kinds of harms. We have some real challenges too in terms of timeliness in other indicators that give us information around overdose, for example. So the only other key indicator that tends to be used is coronial data, and that can have more than a 3-year time lag in routine reporting. So if we want to understand emerging issues and we want to understand harms at a population level and at a local area level, we really need to have timely indicators that allow us to better understand what's going on. This kind of information is really important to inform evidence-based policy and also evidence-based intervention, and how we best evaluate different kinds of interventions to ensure that we're reaching the populations who need the support and improving outcomes as opposed to causing harm. This particular system is also unique and innovative and doesn't exist anywhere else in the world, so it really gives us information not available elsewhere. So, this specific study, we have data available from mid-1998 for metropolitan Melbourne and regional data available from May 2011. And this is unavailable anywhere else in the world and really reflects this ongoing investment from the Department of Health and Human Services in funding this kind of monitoring and surveillance activity, but also that ongoing relationship with an ambulance service to be able to understand what's happening on the ground, what paramedics are actually responding to, and what those impacts are on community. We receive data on a monthly basis, and that includes detailed information regarding case characteristics, including patient demographics, case descriptions, police co-attendance location, and treatment information. And we undertake monthly coding and monthly data analysis, with reports available within 2 months of a reporting period. So we're just in the process now of finalising the report that covers data up until September 2016. So when we think about timeliness and emerging issues where we may be seeing a new drug involved in presentations or a different level of purity of heroin, for example, we can actually see those emerging issues as they're happening and be able to respond in a timely fashion. So it may seem like it's quite straightforward. We get data, we'll do some analysis and we can report on that, but it's not quite as simple as that. We receive data, as I said, on a monthly basis from Ambulance Victoria, and we receive data of cases that are potentially relevant to alcohol and drug mental health or self-harm. So we run a filter through the data to extract cases that may be relevant to our purposes. We then undertake substantial additional cleaning of the data and prepping of the data to enable coders to code for the involvement of alcohol and other drugs, and then we need to do additional cleaning and coding after that occurs, and then there's an analysis process. So it's quite a detailed and complicated way to actually get access to this data. It just doesn't appear already coded and ready to use. So why do we need to do all of that? The primary purpose of data collection for paramedics is clinical and it's administrative. It isn't for research purposes. So much of the information we need is missing or inconsistent. And that certainly isn't a critique of what paramedics do. The way they collect information, how they collect it, how they record it is entirely appropriate for the setting in which that is happening. And we certainly wouldn't want to do anything to change that process because it needs to be fit for purpose for clinical practice. We're asking other questions of the data and we're interested in some specific characteristics, and we can get that information out of additional analysis and additional interpretation of the case notes and other information provided by paramedics. So we take into account the case notes that the paramedics write throughout the record, as well as the checkboxes that they have selected in terms of the type of presentation. So to get the detail we need to do that additional review and analysis. If we didn't do that additional review and analysis, we would miss a substantial burden of alcohol and other drugs on paramedics, and through paramedics on the community and on individuals. We'd miss nearly 55% of illicit drug-related cases, around 80% of medication-related cases, and around 65% of acute alcohol intoxication cases. So when we're thinking about how we most appropriately develop policy and respond to alcohol and drug-related harms, missing such a significant proportion of impact of alcohol and other drugs on the community puts us at risk of not being able to develop appropriate policy responses or be able to evaluate those appropriate policy responses to ensure that we're actually doing good and resources are well directed. So for the purposes of this work, we have some very specific definitions of drug involvement in presentation. We're interested in the immediate or very recent over or inappropriate use of a substance directly contributing to the ambulance attendance. So thinking about that definition, if a patient presents with alcoholic liver cirrhosis but they haven't been drinking in the lead up to the attendance, we wouldn't code that case as an alcohol-related case. If a patient presents and they've had an adverse reaction to a medication that they've used as prescribed, we wouldn't code that case because it's not inappropriate use of that substance. If a person is taking their medication as prescribed and then they haven't had a reaction to it at all and they're presenting for a different reason, that prescribed use, appropriate use of the medication wouldn't be coded. We're interested in immediate or very recent over or inappropriate use. So if somebody were to take a prescription medication along with alcohol and they were contraindicated and that resulted in an adverse outcome, we would code that information because it would be the inappropriate use of those substances. This assessment is based on the paramedic's mention of substance being involved, and that is based on the patient's self-report, reports of others at the scene, and the paramedic's clinical assessment of the patient. We also take into account the patient's clinical presentation when we're doing our coding. So we take an overly inclusive approach in terms of the records that we receive from ambulance services, but then we take a conservative approach in coding. So for example, if a paramedic writes patient has consumed alcohol without further detail of quantity, it would be an alcohol mention case, not an intoxication case. We don't have enough information to support that if there's nothing else in the record. So the data that we have in the system spans across a range of different indicators. We know about the drugs or substances involved, demographics of the patient, the geographic location, including geospatial coordinates, which allows us to do hotspot mapping, for example, the type of location, whether it's indoors or outdoors, a public or private location, and further detail around that as well, which is certainly important when we're thinking about different kinds of interventions, so changes to public drinking, for example, in certain local government areas, it gives us the capacity to be able to explore those kinds of changes, pre and post the change. We have the time of day and day of week, which really allows us to do some great modelling around burden on services and impact on services and how that varies across drug type and population group. Outcomes, for example, whether or not the patient was transported to hospital, if they weren't, why they weren't, whether there was no medical need for them to be transported to hospital, if they required transport and they refused, or if they're being transported through other means. A whole range of clinical indicators are included in the data, whether or not police co-attend, and the patient's past history, where that information is available. So we make our coders do an awful lot of work. In terms of coding for specific drugs, they also code for self-harm, they also code for mental health, they also code for violence, they also code for life stresses, they also code for past history. So they do a lot with each of these records and get through hundreds of records a day each. In terms of drugs included in coding, we're talking about alcohol and drug today, there's a really significant range of substances that are captured in this system and a much more detailed range of substances than in most other systems that provide us information on alcohol and drug harms. So on the left-hand side of your screen there, you'll see a range of illicit substances. So the usual suspects, cannabis, ecstasy, amphetamines, and we code specifically for crystal methamphetamine as a subgroup of all amphetamines. And a range of other drugs, including a separate coding for synthetic cannabinoids and for emerging psychoactive substances, which we code as a group. But importantly, on the right-hand side of the screen, we code for a range of illicit substances. So it's not just the illicit drugs we're interested in. We code for alcohol involvement and alcohol intoxication, a range of pharmaceutical preparations, both prescription preparations and over-the-counter preparations, and we code for specific preparations within those drug groups. So it's not just a case of looking at benzodiazepines as a group, we can actually drill down to specific drugs and groups of drugs that are used. So we can certainly explore changes over time in drug availability and drug use and drug diversion, looking at specific preparations. So I guess a really good example is that in the last couple of years, alprazolam, which is a benzodiazepine, marketed most routinely as Xanax, was rescheduled from Schedule 4 to Schedule 8. So there were further restrictions placed on prescribing of that medication and also availability of that medication due to concerns around a link between alprazolam and violence, and also concerns about drug diversion and drug overdose. So with those kinds of changes, it gives us capacity to see if there's actually an overall reduction in alprazolam use or if there's a shift from alprazolam to other drugs. And we can look within other benzodiazepines or other drugs overall. So there's real capacity to really explore the nuances of changes in drug-related harms and the impacts of different kinds of policies and different kinds of interventions. So now for some data. I'm not going to spend too much time going into too much detail around the data because you have the capacity to really be able to explore this yourselves and explore the areas that you're most interested in. But I guess very quickly here, this is a selection of illicit drugs that we report on and the differences between the number and the rate in metropolitan Melbourne and regional Victoria in 14-15 and the total for Victoria. And I guess what we can see here is that by and large, rates of attendances, so if we take into account that we have different population sizes in metropolitan Melbourne and regional Victoria, rates of attendances tend to be higher in metropolitan areas than in regional areas, with the exception of cannabis. And that's fairly consistent with what we've traditionally seen, that we have more established drug markets in metropolitan areas than we do in regional areas, and that's pretty consistent with other jurisdictions in Australia as well. It's quite a different story in terms of pharmaceuticals. With alcohol intoxication, we do see higher rates of attendances, but they're pretty close in metropolitan Melbourne and regional Victoria. But when we look at other pharmaceutical drugs, we certainly see that on the whole, rates of attendances related to these drugs are substantially higher in regional Victoria than they are in metropolitan Melbourne. So this really speaks to the fact that when we're developing evidence-based policy and evidence-based intervention around alcohol and drug-related harms, we really need to be looking within subpopulations and within local areas, not just at a state or national level, because it's not a one-size-fits-all approach. And just to give you a little bit of an indication of some trends over time in attendances, here we can see the line at the top, by far and away, above the selected illicit drugs here, and it's quite small, so I do apologise, that line up the top there is alcohol intoxication, acute alcohol intoxication. The majority of those cases, there are no other drugs involved. We've seen that increasing over time, continuing to increase over time, and represents about 10 times the number of attendances we see for crystal methamphetamine, for example. The second most common alcohol and drug-related reason for call-out is for benzodiazepines, so illicit group of drugs, prescription drugs readily available in the community. We are seeing increases over time though in methamphetamine-related attendances, and that's really driven by crystal methamphetamine, but also in terms of cannabis-related attendances. And if we just break it down a little bit more here, we can see selected illicit drugs, and that significant increase we've seen in crystal methamphetamine-related attendances has really driven amphetamine-related attendances overall. But we've also seen a real increase in cannabis-related attendances and recent increases in heroin-related attendances in Victoria. In terms of pharmaceutical drugs, we see a little less variability. Availability is quite consistent in terms of pharmaceutical drugs. They're readily available from prescribers and dispensers. What we do see, however, and it's important to note, is increasing trends over time in attendances related to antipsychotics and also to non-opioid analgesics. So these are predominantly over-the-counter analgesics like paracetamol, ibuprofen, and the combination drugs that are paracetamol plus codeine or ibuprofen plus codeine. And we see those in great numbers in ambulance attendances, the majority of which are intentional overdoses. So looking at change from 13-14 to 14-15 in terms of illicit drugs, I think it's really important to flag, and certainly this was mentioned a couple of weeks ago by the Minister when he launched the statewide training for frontline responders around ICE responses to ice, that we are continuing to see an increasing trend in terms of ice-related or crystal methamphetamine-related attendances, and that's really driving the increase that we're seeing in all amphetamine-related attendances. So a 45% increase in metropolitan Melbourne and a 58% increase in regional Victoria. So this is continuing to be an issue. The trend has slowed a little bit, but we're still seeing quite substantial increases in harm over time in terms of crystal methamphetamine. It's important to note, though, that we're continuing to see increases in other drugs of concern as well. Substantial increases in cannabis-related attendances over the 2-year period that we're showing here. And also substantial increases in heroin-related attendances, and this is supported by other evidence that we're hearing from Coroner's Court and from frontline agencies as well, in terms of the increasing prevalence of fatal and non-fatal overdoses, causing significant concern in the community. That disproportionate increase we're seeing in regional areas also raises concern as well, because traditionally we've seen very low rates of heroin use and heroin-related harm in regional populations. In terms of alcohol and pharmaceuticals, and bearing in mind the high numbers of alcohol-related attendances, despite the focus on changing culture and increasing awareness around alcohol-related harm, we're still continuing to see around a 10% increase per year in alcohol-related ambulance attendances where the patient is acutely intoxicated. We're also seeing some real shifts around pharmaceutical drug-related attendances, particularly in regional areas where we're seeing increasing harms for benzodiazepines and also for antipsychotic drugs. And we've had quite a bit of anecdotal reporting of the use of antipsychotics in place of benzodiazepines in some areas, off-label prescribing, so it's a cause for concern. In terms of alcohol intoxication-related attendances, just a little bit more context around the characteristics of these attendances in metropolitan Melbourne and regional Victoria over the 2 years. What we can see is some relative stability in some of the indicators. We've seen those significant increases in overall numbers of attendances. In terms of other drugs involved, and as I mentioned before, the majority of these acute intoxication cases, the only substance involved is alcohol. And we've often had the argument put forward in the media and elsewhere, both in response to this kind of data, but also into other indicators of alcohol-related harm, and calls for changes to alcohol availability and further regulation of the alcohol industry, that what drives alcohol-related harm is actually other drug use. It's people going out and using other drugs, and that's what's causing the problem. That isn't what the evidence supports. There is no support for that argument whatsoever, and we see around 6% of acute alcohol intoxication cases have any other drugs involved, and that's been consistent over time. In terms of the average age of patients, whilst we often focus on youth populations and risky binge drinking among young people, which certainly is a concern, I have 3 young men as sons, one of whom is in the audience today, so I'm particularly concerned about the risks associated with youth binge drinking. However, again, the evidence that we're seeing is increasing harms in non-youth populations. I'm very mindful not to say older populations when we have an average age there of 40 and 41. But what we are seeing is disproportionate increases in ambulance attendances related to acute alcohol intoxication for people in their 40s, 50s, 60s and beyond. And that's where we're seeing the greatest increases. And if you're interested in discussing that further, one of my colleagues, Sharon Matthews, is actually focusing quite a lot of work around those drinking patterns and alcohol-related harms among baby boomers and beyond, because that's where we're seeing the greatest increase. We're seeing overall stability or reduction in alcohol-related harms among young people, but increases among mid-age and older populations, which is a real significant cause for concern, and certainly not where the primary focus of much of our media attention, but also community education is. And how we address those concerns is a real issue. And I guess when we're thinking about both these acute harms, we're talking here about acute harm. This isn't driven by chronic conditions, but the combination of acute harm and the complications of chronic conditions, the complications of changing medication, we're talking about a significant issue that's only going to increase. In our other indicators, we're seeing increases in chronic alcohol-related harms as well. So these issues are occurring concurrently and are representing an increasing burden on society, but also on our health system. We've seen relative stability in the proportion of males and females. It's around 2/3 male, 1/3 female who are presenting to ambulance acutely intoxicated. And around 25 to 30% of these cases are also co-attended by police. So the impact on emergency services is quite significant, not just for paramedics but also for police. So multiple frontline responders at the scene at the same time addressing issues of alcohol-related harm. And it's around 70 to 80% are transported to hospital. And that varies depending on age. Older populations tend to be transported to hospital more commonly than younger populations, but that varies quite a bit. And just to give you a little bit of an indication, these are some maps that have been taken directly off our new website, which I'll speak about in a moment, looking at the different distributions of alcohol intoxication. So the top left-hand map is all attendances. The bottom left-hand map is presentations for females. The top right is males. I hope that's true. Yes, that's true. And the bottom right is youth, so 15 to 24-year-olds. And what we can see there is very different distributions just by looking at that quite broadly, and we can certainly drill down on it further, very different distributions of subpopulations within populations at a local area level experiencing these kinds of harms. So further being able to identify that in this particular local government area or this particular region, it's actually women and young people or young women who are experiencing disproportionate acute alcohol-related harm allows us to better think about how we respond, how we educate and how we support to improve outcome. I don't think I would be allowed to stand up here today and not talk a little bit about crystal meth-related attendances. They're continuing to pose real challenges in terms of treatment, in terms of community experience of harm, and also in frontline responses. But what we can see here is relative stability and indicators over time. So we're seeing the same age characteristics, the same gender characteristics presenting to ambulance, both in metropolitan and regional areas predominantly. Police co-attendance is much higher for crystal meth-related attendances than it is for alcohol-related attendances, and a higher proportion are transported through to the ED. So thinking about that impact on ED is really significant. It is also important to note that we're talking about 20 to 25% of cases not being transported through to the ED. So we have many people who aren't having that follow-up treatment and care. And whilst it's important to recognise that the ED is often not the best place for people to go when they're experiencing acute harm, sometimes it is, sometimes it isn't. We really need to be thinking about what follow-on care, what support, what engagement with further help seeking may be available to support people who are in crisis and require further follow-up but may be unwilling to engage with the emergency department, or that may not be the best place for them to actually receive the support that they need. And just the trend over time in crystal methamphetamine related attendances, I think it's quite self-explanatory. This is a significant issue for the community, it's a significant issue for treatment services, and it's a significant issue for the sector in how we most appropriately respond to this and address these issues. If it's a little bit hard for you to see the legend, the two long lines that quite evenly match, that's the number and rate of attendances in metropolitan Melbourne, where we have the full 10 years of data, and the two shorter lines are the number and the rate. The rate is the higher number, or the higher line, in regional Victoria, just to give that comparison between metropolitan and regional rates. And here again we have the distribution, so the same ordering of maps, so all attendances, females, males and youth. And again we can see a really different profile across local government areas and across regions in the harms that we're experiencing. So if we take a one-size-fits-all state level approach, we are potentially going to miss higher risk populations at that local area level. So now I want to really quickly talk about this exciting new way to access this data. In previous years, I'm sure you would have all come to these seminars and seen media releases and gone home and downloaded a very beautiful but very long 200-page PDF report where all of the information was static. That is no longer available. On our website you can access a summary, which is a 2-page summary, so nice and easy to read, of overall patterns of attendances and those characteristics. But you can now access all of this information and more in much more detail for your local area or for your population group of interest at Ambo-AODstats.org.au. And I'll give you a couple of pictures of what you can do rather than going to the live site, because I think it's really important for people to be able to explore it in their own time to the level of interest that they have. So this is just a screenshot of alcohol-related attendances and gives you a bit of an indication here of the kinds of things you can do with it and how interactive and user-friendly it is. So on the top left-hand side of the screen, firstly, you choose the substance that you're interested in, you choose the population you're interested in, and you choose the kind of indicator that you're interested in. So you can really explore different characteristics. Then you can look at state level maps, metro regional maps, or here, local government area level maps. And we've already created regions for the 8 health regions. So if you're interested in a particular region, you can choose that and look at trends over time and look at characteristics of attendances for the region you're interested in. But you might be interested in a particular custom region. You might like to create a region of your own or compare different local government areas. And here we have Melbourne, Port Phillip and Stonington as an example for alcohol-related attendances. And you're able to map and compare over time what's actually happening in that kind of indicator. All of this information can be downloaded. The maps can be downloaded, so you can select the areas you're interested in, download them, put them straight into reports, put them straight into presentations. The data that sits behind this is all aggregated. You can download data tables and play with them yourself. And you can download all of the graphs as well. So it gives real capacity to be able to capture the information you specifically want and pull it out and be able to use it in a way that best meets the needs for service planning, for education, and for whatever kind of response that you're particularly interested in for study purposes and for general interest for those of us who are data nerds. But certainly a great deal of capacity to really explore the characteristics. And many of the characteristics we used to only report at a state or regional level, like police co-attendance or transport to hospital, patient demographics, is now available at a local government area level. So there's much more capacity to really understand what's happening at that local community level as well as regional and state trends and how they might differ and where there might be specific needs. So this is another very pretty for the more enthusiastic data nerds amongst us. There's capacity to actually plot multiple indicators and multiple factors and to be able to explore different distributions. So this is a scatter plot. These are heroin-related attendances, and Yarra is the LGA for both. This gives us both male and female numbers of heroin-related attendances. And so you can actually see where different local government areas plot across different genders. You can actually look at co-presentations, so look at cannabis plus heroin, where do different LGAs plot. So where different burdens actually cluster for different local areas, for different services, and for different communities who may be experiencing different kinds of harm. So there's a lot of capacity there to really explore different issues of interest. So we always have to acknowledge that no single data set can do everything we might want it to do. It's simply not possible. And as I mentioned, the information that we have here isn't collected for research purposes. So there are some characteristics of interest that aren't collected or may not be reliable and we can't report on them. We don't have biological testing. Paramedics are not doing tox screens on site. It's not appropriate. It's not happening. We do not have an independent measure of blood alcohol concentration. We base our information on self-report and clinical assessment, but most other indicators are based on those as well. We also don't have things like full diagnostic screens. Again, not appropriate for paramedics to be conducting those in the field. We have very detailed data though, and actually more detailed data than we would have with routine coding like ICD coding that's used in hospital and ED settings. But we need to acknowledge that this data isn't going to give us everything we need, and there are ways to get that additional information by linking in with other data sources and doing other forms of research to get that information, following up with patients, following up with paramedics, data linkage, a range of ways to go. And it may seem self-explanatory, but obviously this data isn't going to include events where an ambulance isn't involved or an alternate service is used. For major events like major sporting events or music festivals where St John's Ambulance are available, if the patient needs further care or the patient needs transport, Ambulance Victoria are then involved, so we do capture that information. But there are times where if an ambulance isn't there, we're not going to have that data. So if people are walking into an ED, clearly we're not going to have that data, but we can use this to better inform how we understand populations experiencing quite severe and acute harm. But the flip side to those limitations is this data is incredibly rich and it provides us with a whole range of opportunities. We've actually started piloting work looking at the role of violence in presentations, and this is a really serious issue and a really significant issue in terms of interpersonal violence, in terms of family violence, which we see a great deal of in our data. but also in terms of exposure to occupational violence. So the violence experienced and the aggression experienced by paramedics and police when they're responding to cases is becoming more and more of an issue, and certainly in Queensland we've seen a number of cases of paramedics being very severely injured by patients, and it raising issues around safety and also raising issues about reluctance to respond, and implications in terms of morale in workforce, but also sustainability of people in those roles where they're experiencing these high stress environments. This data also informs other projects like the sister site of Ambo-AODstats called AODstats. It allows us to undertake work looking at clustering, including geographic clusters, temporal clusters, population group clusters and behavioural clusters, so we can look at emerging issues as they occur in specific geographic locations, but also in terms of correlates of harm that we see. There's real capacity to use this kind of data to look at data linkage, and just in the last few weeks, in fact, we've received data to enable us to actually look at repeat presentations of patients from 2007 to now and on an ongoing basis. So not only will we look at attendances, but also repeat presenters to ambulance and to other services. So that really allows us to look at trajectories and how patients actually engage with different services through a pathway of care, and where there might be most appropriate points of intervention and referral to reduce harm and also to reduce workload and burden on quite stretched resources. This kind of data gives us the capacity in the future to explore outcome monitoring and to do that in a routine way. So if we're interested in outcomes following treatment engagement, this is a really good indicator of acute harm at a population level without having to chase up individual clients who may not want to have follow-up, but we can actually see if they're requiring acute services. We can undertake time series analysis, and certainly have in the past, to be able to explore policy and other factors that may influence changes in service demand and also changes in burden on services and impacts on the population. Further exploration of correlates of harm and their impact. And it allows us to support enhanced planning and referral models, to have a really strong evidence base that's unit level, that allows us to really understand what's happening on the ground and how different interventions might actually influence that at the first responder end right through a treatment pathway. And finally, it also allows us to explore policy and intervention strategies, both the development of policy and intervention strategies, but also evaluation, because we have this lovely long time series of data. It's ongoing data that's collected throughout the state, and now in other jurisdictions as well. It's collected around Australia. We have the capacity to be able to explore the impact of different kinds of interventions and policies at a local area level and at a state level, because we have the capacity to compare with previous time periods, but also control areas where those interventions may not be occurring. So if something's implemented in one local area or one state or territory, we can actually compare against other jurisdictions to see what's happening, taking into account any other policy changes that may have occurred. And historically, I guess that's been one of the challenges with interventions. Often they're implemented to do good, and towards the end of that intervention there's a need to do an evaluation of the intervention to see if it's been effective, but often there's actually no evidence to support that evaluation. The evidence hasn't been embedded from before the commencement of the intervention, so there's no way to evaluate the efficacy of an intervention that may be incredibly effective with a patient population or a client population, or potentially an intervention that has done absolutely nothing and cost a lot of money, or worst case scenario, an intervention that aimed to do good and to improve outcomes but actually resulted in worse outcomes as an unintended negative consequence. So in summary, alcohol and other drug harms are complex and they impact individuals, their families and friends, emergency and health services and the broader community. We need innovative and evidence-based approaches to be able to address these issues, and that at a local community level as well as at a state and national level. Through monitoring emerging trends within and across communities, we're able to develop and evaluate policy and intervention strategies in an effective and a really evidence-based way. Thank you all very much.